Okay, so anterior drawer test, your patient's hip is in 45 degree of flexion and the knee in 90 degree of flexion, and you need to, the examiner is, patient's foot is held on the table by the examiner's body. So usually what I do is I'll sit on their feet. Yeah, on your exams, on your board exams, you sit with that, but it's okay. Here it's fine. In your clinic, you can just sit like that. And the examiner's hands are placed around the tibia. And then what you are doing is actually trying to open the drawer. And then if there is more laxity, more than 6 millimeter, that means they have a ACL strain. Okay? Any questions?
How are you measuring this?
You are not measuring, you are
feels like
assuming.
okay.
Yeah, they say 6 millimeter, but then you know when you feel it, you can actually feel if there is more laxity. In this case, I cannot move her tibia more further, versus in case of an ACL injury, if it is a complete sprain, then you can actually move it pretty forward.
Just kind of comparing both sides.
Yeah, you should also compare both sides. Yeah. Is that clear? So next one is Lachman's. In Lachman's test, it's very similar to the anterior drawer. The patient's femur is stabilized while the proximal aspect of tibia is moved forward with other hand. So in here, the patient's knee is between extension and 30 degree of flexion. You just keep their knee in 30 degree of flexion, and then you are kind of, my hands are really small to give that pressure that way, so I will just stabilize it and then do like an anterior glide on that tibia on femur. So basically you give a posterior or stabilize the femur. You can give also a little bit of pressure downward to the femur posteriorly, and then you just have to pull that tibia anteriorly on femur. So if there is a laxity, that is a positive. Again, soft and feel if tibia is moving forward on femur and disappearance of infrapatellar tendon slope. Okay, so the only difference is in this one you keep 30 degree flexion, the other one is like 90 degree flexion. In the other one, as there is 90 degree flexion, you don't really have to stabilize the femur, you are just moving the tibia anteriorly, just like opening a drawer. In Lachman's, you have to keep it here, and then as it is less stable, and then you are trying to, this is more like a joint mobilization where you are actually trying to move tibia anteriorly or do a glide anteriorly with the femur stabilized here, or you can also give a little bit of pressure on the femur posteriorly. Any questions? No. Okay. Posterior sac sign. So these are for anterior cruciate ligament. For posterior cruciate ligament, you are actually asking your patient to keep their knees in 90 degree, and then you are observing for a sac sign. So if they have a PCL strain, they will be having a sag in that posterior side compared to the other side. So you are comparing both sides, and if there is more sag, then that is the positive. So the positive is tibia drops or sags on the femur because of gravity if there is a posterior cruciate ligament torn. Make sense?
Like, what is that look like? Is that like, cause it's like super mild, how can like...
Yeah, so when they both their knees are in 90 degree like this, and then if one of them is dropping more down than the other one.
You mean the leg?
Like this?
Like
No. Just like, you know, there is a slope down. I cannot do that in her because she don't have a PCL strain. But usually it's more like when you compare here,
so you compare
there is
the-
more sag in the posterior side. This is a little bit sag, more sag. Yeah, or let's say the gastrocs will see more down. Not the leg goes down, just the gastrocs go a little bit more down. Okay, so there is posterior drawer, which is more like you actually keep the same 45 degree hip flexion, 90 degree of knee flexion, and then you are actually sitting on or just stabilizing their feet, and instead of doing that anterior drawer, we are doing a posterior drawer here. So you are grabbing onto the tibia, and then you are trying to put that drawer back. And if there is more laxity in that moment, going back, if there is laxity in that moment, that is again 6 millimeter eyeballing. And if there is more laxity, that is posterior cruciate ligament tear. Okay? What else? What else? MCL and LCL. This is pretty straightforward. You just keep your patient in supine and the knee is full extension. Examiner applies a medial force at the knee, so valgus or varus, depending on valgus or varus. You are actually, if you are doing like a valgus, then do a little bit of internal rotation, keep little bit pressure here, and then valgus stress. Versus in the other one, you are doing a varus. And you can also do it in flexion, 30-degree flexion, and then you do the same. You just hold on to their leg. I find inflection is more hard because it depends on your patient's weight. Yeah. So if it is hard for you, you can even do it in full extension. But if you can do it, if your arms are really big and strong, then go for it. Like hold it and then just apply a force like this.
Could you pillow? Would that make sense?
You could, yeah, you could. You could pillow. Yeah, actually that's a really good, thanks Roxanne. Yeah. Yeah, so you could actually pillow and do it as well. Yeah. Any questions?
Question like for this test you need to do extension, right? Extension first and 30-degree reflection second, right?
According to the slides, yes.
Okay. So for OP it's like we do both or we just like choosing one for doing it, that's
You have to do both.
okay.
Because it's in your slides, you have to do both. But in your clinic, I normally just, because their legs are usually in this position, in the resting position, and I just do it in this position. Actually with pillows, yeah. Yeah, I
I'm
forgot
teaching this
that.
class now.
Yeah, so actually I do it with pillows in clinic because the pillow is already there. So I just do it with that. Oh,
I just want to share my experience with the ACL.
Go ahead.